deciding if it wants to cooperate. So far, nothing.
Go live on Facebook. It's 8 o'clock, I think. Yeah. You're live.
Oh, we're live. Hi, everybody. Welcome back to Fertility Fact or Fiction. We are going live right now. We'll give everybody the traditional few minutes to sign on, and we'll get ready to go. And we have a new format, and we're now in my office.
So here's your comments.
Oh, yeah, perfect. Yeah. All right. So I have an escape door in case I need to run. And welcome back. So, oh, we need sound. I don't have sound.
Oh.
I'm getting sound, don't worry.
Okay, here we go.
You got sound now?
They have sound, but we have it for...
Yeah.
Yeah.
You should be able to hear me. Can everyone hear me? Thumbs up if you can hear me on Instagram.
Even Facebook for that matter.
Hi, Mara. Mara Menard just joined, our amazing office manager. So we're just going to give everybody a minute to sign on, and then once you've all signed on, we will begin the show. Welcome back. It's been a busy week. I've been very busy with meetings and consultations and trying to figure out when we're going to reopen. I was at our new Sarnia clinic today, which looks amazing, and we're really excited to be reopening hopefully soon. So lots going on in the world. There's some very interesting new data out today as well in regards to both pregnancy risks from COVID and male fertility risks from COVID. So I will be sharing that with you all today as we go through the discussion. And we got sound, so that's good. Awesome. Everybody's staying safe, hopefully. And your families are all well. You are sheltering and avoiding close contact with anyone. That would be excellent for all of us. Still necessary, although I think we are very, very slowly, hopefully kind of flattening the curve. So I think we're on our way to where we need to be. It's just a matter of continuing to do the things we need to do to stay on the right track. So I guess I'll get started and we'll get everything going, and then we can discuss everything with you guys. So I've had a lot of requests recently for patients who wanted us to do tubal reversals for them. And we've got a number of women who have kind of requested this and lined up when surgery is available again for elective procedures for us to do the tubal reversal. So just so we're all on the same page, a substantial number of women will have a sterilization, which is when you tie your tubes, and that can be done either with suture, with cautery, or with a little clip, usually called a Filshie clip, or this little plastic ring, which is called a silastic ring. So when we use those and we tie the tubes, they can, in certain instances, be untied by surgically going in, cutting the two segments of the tube, which are still fresh and viable, and then reattaching them without the blockage in the middle. It does require an operating microscope, and if you looked at the ad for this week's show, you'll see that that's myself and Dr. Carrie Mayrand operating on a patient with this giant kind of overhead microscope that we use to look and get a very close-up zoomed view of the pelvis, and that way we can use very, very fine suture. It's an 8-0 suture, which is so thin you actually have trouble seeing it without the microscope there. And we use that to put the inner part of the tube together, and then the outer part we do with a slightly thicker suture, and then it all goes back together. You do have to have a bit of a surgery. The incision's usually about 3 or 4 centimeters, maybe 5 or 6 if the patient's a little bit bigger. And then we go in and connect everything back together, and you sew it all up. And we don't keep the patients in the hospital for that. We send them home. So the reversal is the undoing of the tying of the tube. About 39.5% of women will undergo sterilization during their lifetime. And we do know that many women regret it later on. Age, new partner, number of children that you've had, changes in your life circumstances, all can combine to lead to regret or sort of not being as happy or content with the decision to do the tubal reversal. So the tubal ligation. So the reversal offers patients the opportunity to correct that or to undo that, and that way have a chance to conceive again. So the question is, if you're over 40, what's better? Is it better to untie your tubes, or is it better to do IVF? And so there's a recent debate in Fertility and Sterility, our big fertility journal, that highlights this. Now, there is some important information you need to know. As I mentioned, almost 40% of women will undergo sterilization, and some estimates say it's as high as 50% at some point during their lifetime. So there are some critical elements to this discussion that are really important to highlight. Number one, if you have burned your tubes or you've removed your tubes, with the burning, it is very difficult to put them back together, and with removal, it's impossible. So this is only really specifying women who have either had their tubes tied, they've had their tubes clipped, or they've put on that little silastic ring. For the burning, it's much more difficult. It is possible, it doesn't work as well. And obviously, if your tubes have been removed, it is not possible to put anything else there in its place. And we certainly don't do tubal transplants or anything like that as of yet. So bottom line is, it applies to a small segment of women. From those women that have undergone that kind of tubal ligation, we know that about 14.3% will actually request information in the overall population for having a reversal or undergoing some type of fertility procedure such as IVF. And if you had the procedure when you were very young, less than 24, then that rate skyrockets to almost 40%. So we know that there is a significant number of women who suffer from regret after having had their tubes tied for whatever reason, whether their life circumstances have changed, their partner has changed, or they just want another child and they're still in the same family relationship. So that then puts the impetus on us to be able to answer the question of, are we going to provide patients with IVF, where we can bypass the tubes because we don't need them? We can make you make eggs, go into your ovaries, take out the eggs. Everything is done outside the body. You produce an embryo, and the embryo then gets placed inside the uterus, and you bypass the tubes entirely. Or should we offer these women a tubal reversal? So Fertility and Sterility took on this debate. Now, it's interesting because their own guideline from many years ago says that the tubal reversal is actually the better way to go. But there is some new data which is interesting to at least examine, and so we're going to talk about that tonight. So the first thing you need to know is, obviously there's a demand, and we've highlighted that tonight and talked about it. The second thing is that there is differences in success. So when they've looked at the studies in regards to tubal reversal, there are actually 15. Now, one of them is much, much bigger, involves thousands of patients, and the rest of them are much smaller. But overall, when you amalgamate all of the 15 studies together, you're ending up with a 41% pregnancy rate and a 35% live birth rate if you have the tubal reversal done. So that's the surgical approach to this. When you look at IVF, for women between 38 to 40, if you look at the American collaborative data, it's from an agency called SART, the Society for Assisted Reproductive Technology. It's close to about 40% for women between 38 to 40. For women between 41 to 42, you're looking at about 13.4%. And for women over 43, you're really looking at a less than 5% chance of success. So it does appear that there is a substantial difference in success. Now, if you look at that one study that involved the thousands of women, it's actually pretty equivalent. And if you're looking at women who are exactly 40 years of age, they actually seem to do a bit better than in that one study with the tubal reversal. But when you pool all of the studies together, it does appear that the tubal reversal actually may give you a bit of an advantage. When you look at the overall concept of this, the other big advantage in doing a reversal is that it's a cure for the problem of infertility, whereas IVF is a treatment for the problem of infertility. We cannot promise you that the treatment will work. Nobody can. But you can promise that the tubes will become functional again. So there are some advantages there in terms of doing the reversal because you have now cured the infertility problem. And most people would prefer a cure rather than a treatment. So it definitely makes a lot of sense to proceed with the cure approach than it does to the treatment approach. The one concern we have when we do tubal reversals is the chance that you can get an ectopic pregnancy. So an ectopic pregnancy is when the pregnancy is actually in the fallopian tube. It's stuck there, it can attach there, grow there, and if it grows in the tube, that has two very significant sort of implications. Number one, it is not viable and must be terminated. And number two, it frequently requires surgery because it can be life-threatening. And if you undergo life-threatening treatment, there is frequently the cause to take out the tube. So now you've paid to have your tube reversed and you have to go and remove the tube. So it is not an ideal situation. So the studies from the IVF side support the concept that ectopic pregnancy risk is a little bit lower, and it probably is when you're doing IVF. I've only had two ectopic pregnancies in our program over all the years that we've been doing it, so it really is very, very rare. Whereas with a tubal reversal, I tell patients going into it that the chances are at a minimum 5% and possibly as high as 15%. Now, if you look at the studies, they say it's somewhere between 2 to 6% for tubal reversal, and IVF is saying it's around 5% traditionally as well. But I definitely think that in my own experience, the chances of a reversal causing an ectopic are definitely higher than IVF. And certainly we use IVF for patients that have had multiple ectopics because it is a safer route of pregnancy for them than natural or insemination or tubal surgery. So I don't agree with the authors on that one. The pro-tubal side argued that it made a lot more sense to do the reversal because the numbers were essentially the same. I think that's probably not very realistic. I think the numbers probably favor IVF when it comes to your ectopic pregnancy risk. The last question is a question of cost. Now, this is an American study, and just for entertainment purposes, for those of you that are Canadian, I will share the cost difference with you. The cost, they said, of IVF was to have one baby was $111,445 versus the tubal reversal, which somehow cost $218,742. Now, clearly, nobody is paying that much for their fertility care on a normal, ongoing basis. And I only charge somewhere between $5,500 to $6,000 Canadian to do a tubal reversal. So I have no idea where the cost of $218,000 came from. So it is definitely not that expensive. IVF is also not that expensive. But what you need to factor into this is that you may undergo the surgery, there's time off of work, your partner may need to take time off of work, there may be medications that you need to purchase for your recovery. The recovery can take a fair bit of time. Most people take about 6 weeks off of work, so there's a component there of time loss. Maybe you now need a babysitter for existing children. And same thing along the lines of IVF. You may have to get meds. You may need to try more than once. You may do the tubal reversal, have an ectopic, and then end up needing IVF after all anyway. So all of these are factors that go into it. Nevertheless, clearly on a one-to-one, apples-to-apples comparison, a reversal costs about $6,000 and IVF will minimum cost you $10,000. Plus, if you're over 40, which is the age group we're talking about, you then have to add in the fact that you now are adding in about $5,000 worth of medication. And we do recommend the pre-implantation genetic testing for that age group. So that's another several $1,000s. So $6,000 versus somewhere between, let's say, $10,000 to $20,000 for your IVF cycle. There is no question that the reversal will at least initially be cheaper on that apple-to-apple comparison. Now, the one other aspect of this that's important is if you do it right at 40 and you're young, you may have enough time to have one or maybe two babies from doing a tubal reversal, assuming that your ovaries are functional and they're doing well and you're a healthy patient. If you do IVF and this is a big you produce enough eggs, you may have enough embryos to use later on that are still healthy and viable and can function. And so you could potentially have more than one child that way. The flip side can also be true though. So if you do your IVF cycle and you only produce one embryo, you're now stuck with just the one normal embryo. And so you're only going to have the one chance. Whereas if you do the reversal, you still have other chances down the line. And some people won't wait. They'll have one baby and then they'll breastfeed for maybe 3 to 6 months. And then they'll be trying again almost immediately for another one. So they're having both children before they're actually 43 years of age, where it genuinely starts to become difficult. So the fact or fiction this week was what's better, a tubal reversal or IVF for women over 40? And I think that the balance of the evidence actually supports an individualized decision. So I'm going to cop out of this one a little bit this week. We won't get that hammer we get in our videos. There's no stamp for this one. So the reality is that, you can really go either way. It very much depends on your ovarian function, your personal preferences, how your surgery was done initially. Did you actually have cauterization of your fallopian tube, or did they operate on it surgically and just clip it or tie it? Was it sewn at the time of C-section, etc.? And then you also need to know all of the other aspects of your health and what your tubes were like. Have you had chlamydia before? Have you had gonorrhea before? Was there endometriosis? All of these things can alter things. The one important note here is that both groups arguing for both sides of this clearly stated that if you have more than just tubal factor as your diagnosis, so endometriosis, previous infection, recurrent pregnancy loss, diminished ovarian reserve, any of the other things, male factor that we deal with, IVF is a better option for you. So I think apples to apples, it's definitely cheaper to do a reversal, and you can get very, very good success rates with it. And we've had a very high success rate in our program doing that. But you do need to individualize this for your care. And some people actually may benefit a little bit more from doing IVF, in particular if they have other issues going on. So with that, I want to do something I don't always do, which is not jump directly to your questions, but rather I want to talk about two other really interesting studies that have given us a bit of pause and a lot of information. So there is an as yet unpublished but pre-released study on 12 men from China where they analyzed their semen for COVID-19. And all of these men had mild to moderate symptoms. So only one of them, only one patient actually had severe symptoms. Everybody else had mild to moderate symptoms. And in that population, they actually showed absolutely no COVID-19 in the ejaculate. And one guy actually had a testicular biopsy, and there was no positive virus or particles of the virus in the testes. So it does look like you cannot sexually transmit, at least from male to male or male to female, the virus. And that's really, really important to know, because obviously everybody's been asking, what's the risk of getting pregnant at this time? At least from the male perspective, it does not appear to be a significant risk. The other study that is coming out is in the American Journal of Obstetrics and Gynecology. And during a teleconference last week, one of the physicians from the US mentioned that there may be risks of something called vasculitis, which is inflammation of your blood vessels, when you are going through COVID-19 infection. And as a result of that, those patients would definitely have higher risks in pregnancy, because pregnancy with vasculitis is very risky. The last thing you want is inflamed blood vessels when you're going through a pregnancy. So the study has stated that there was an increase in risk of miscarriage, but before you panic, it is a very, very poorly done study with loads and loads of errors, actually. And one of the guys reviewing it has actually said that this should not even be published. It should be retracted, because it does not appear to have appropriate information in it, or the adequate information that we need, and the rigorousness of the science that we need. Some of the references they use saying that there were first trimester miscarriages actually didn't even have any first trimester miscarriages. So far we have no concrete evidence that COVID-19 affects male sperm, and we have absolutely no evidence to suggest that it is increasing risks in pregnancy. So it does still look safe. And I know that as a society in Canada, the Canadian Fertility and Andrology Society, we are currently going through the motions to come up with a standardized operating procedure to look at reopening the clinic. So we are moving in that direction. We have not issued any statements yet as to when or how or where or why, but we are going to be moving in that direction. And I anticipate that that'll probably happen over the next few weeks to months for sure. So it does look like this is pretty safe. We are not seeing a substantial increase in risks from any centers in Canada. I'm not seeing anything from the US except for this one very poorly done study. So we do think it's going to be quite hopeful. So with that, I am happy to take your questions. And if any of you have questions, by all means, fire away. I probably missed some. Oh, do you? Mm-hmm. Okay. So Tarek from Ibrahim Strategies Group is here, and he is going to ask me some questions. Go ahead.
Okay. Okay, from the beginning. Got a bunch here.
Okay, fire away. I'm having coffee.
Any idea when IUIs will start up again from an anxious?
Yeah, so as I just mentioned, very, very soon. I suspect that we will most likely start in the next few weeks to months. I don't want to pin down a certain date, but I will tell you that we anticipate it should be soon. And I am definitely hoping to target being up and running sometime in May for IUI, as long as the curve flattens. So please don't ask to do it right away. We need to make sure the curve flattens, but we have taken every precaution. The guidelines that we've developed specify what techniques we need to use. There will be a lot of screening involved, pre-screening, screening at the door, and then safety measures once you're here. So I think we'll be able to do it safely shortly, but I'm not going to commit to a time just yet.
Should NK cells be tested for unexplained infertility?
Oh, we need my friend Fred Dzneku from Toronto, or his wife Chloe Romain. So NK cell stands for natural killer cells. It is a type of cell population that can be present in the uterus, and those cells frequently are thought to increase the chances of both failure of implantation of an embryo and miscarriage. There is a whole school of thought that believes that it should be tested, and there is a whole school of thought that says that it is nonsense. So I'm more in the school of thought that thinks that if you've had recurrent implantation failures, recurrent pregnancy loss, or unexplained infertility, that it's worthy of investigation. It is kind of difficult to treat in Canada in particular, because typically you need a combination of IVIG and immune suppressants like Humira, which are incredibly expensive. So it's not that we can't treat it, we can, but you're literally talking about thousands and thousands of dollars. And the evidence to support the benefit is not strong. Now, that's not to say it doesn't work. There are many, many, many people who swear by it, and I believe that it does work in certain cases. But I don't think we should be universally testing for it. I think that it's important in some patients, but I don't think it's something we should be applying to everybody.
Does celiac levels have an effect on fertility?
Celiac levels or celiac disease?
Levels.
There's no evidence that celiac levels have an influence, although there are some studies that say that women with celiac disease or gluten sensitivity have lower rates of fertility and higher rates of miscarriage. It's kind of hard to figure out whether that data is accurate or not. So again, I'd be a little bit cautious about jumping into a gluten-free diet, which is a tough diet to follow. Having said that, if it is causing inflammation, in particular in gluten, actual sort of true gluten sensitivity, then the inflammation we know will be adverse or deleterious to your fertility. So if you have genuine inflammation, you're experiencing terrible stomach aches, there's frequent diarrhea, you have malabsorption, anything like that, it is definitely in your best interest to avoid having gluten and stick with something else. Let me take one from Facebook. Okay, so for your donor egg IVF patients, what is your protocol for your patients? If there is anything you do with your patients where you've seen a higher rate of success? Okay, so first of all, I'm extremely proud of our donor IVF success program. Our donor egg IVF success program has been sky high. So traditionally, we're up in the over 90% range. So it's been very, very good. What we do to achieve that is a bit of a trade secret, but I will share it with you because I want everybody to get pregnant. So obviously we screen the donors, number one, extremely, extremely carefully. So I make sure that they are not smoking, drinking, or using drugs. We have a long discussion with them. We make sure they're the appropriate age, that they understand the process, and that they are being responsible about the process. So it's really critical that they take their meds on time, they show up for their appointments on time. Choosing the right donor is critical to the success. And part of my job is making sure that you choose the right donor. Now, I don't get involved in the selection process, but I do screen them after you've chosen them. And if I feel that they are not suitable for you, I will be very honest with you and tell you that that donor is not ideal for your particular case. So that's number one. Number two, we want to make sure that the donor is going through the process correctly from our end of things. So there are changes in the protocol that we can use that improve your success rates. For example, reducing the number of aneuploid or genetically abnormal embryos can be done by altering the ratio of urinary versus recombinant injections that we use in patients. So traditionally we use Gonal-F and Menopur. Gonal-F is recombinant and Menopur is urinary derived. And there is a certain ratio you want to achieve between those two to maximize the chances that the embryos will be normal. You want to use a Lupron trigger, and you want to give them a little bit of HCG in order to minimize the chances of the donor developing ovarian hyperstimulation syndrome, but maximize the chances of success for your pregnancy moving forward. And so there are some tricks we use. We make sure their vitamin levels are appropriate. We check everybody's vitamin D. We make sure their thyroid levels are okay. I make sure they don't have thyroid antibodies. So yeah, there's a lot of things that go into it to make sure that those patients are ideal and that they are getting ideal treatment from us. And then we do a really good job with our IVF and our ICSI, and we do a really good embryo transfer and preparation of your lining. So there are many pieces to every IVF puzzle. It's never just one thing. And because of that, we focus on making sure we've addressed every single part of the puzzle for you to get you the absolute best success rate we can. One more here. Before COVID, we planned with you to do my next IUI cycle. Would have been this month. You prescribed me 7.5 milligrams letrozole to take before the procedure, but it was canceled, understandably. I still took it this month, trying at home. If IUI doesn't start up by my next cycle, will you refill? Oh yeah, absolutely. If you ever need me to refill a script for you for something like that, I'm more than happy to refill your script. So just call the office. You don't even need to come in, and we will happily refill your script for you. Not a problem. Yeah.
What is the normal reference rate for sperm HDS?
HDS?
That's what I got.
I'm not sure what you mean by HDS. If you are talking about sperm DNA fragmentation, the high fragmentation should be less than 15%, ideally to be good to excellent. Less than 25% to get out of the fair to poor quality. There's another element called high DNA stainability, which is the combination of the moderate DNA fragmentation and the high DNA fragmentation. And that needs to be less than 25%. So I don't know if that's what they're asking.
Okay. That sounds like an HDS.
Possibly. Yeah.
You want me to go or not?
Yeah, you go.
Okay. What can I do if I find that I'm not ovulating every month? I've been using ovulation strips.
So we need to see you. We need to figure out what to do to improve, well, first to diagnose what's wrong. So you're either not ovulating because there is PCOS, which would be the most common. You may not be ovulating because your ovaries are becoming weaker, which would be more like a menopausal situation. Or there can be other circumstances, hormonal abnormalities, stress, severe extremes of dietary changes, weight loss, weight gain, and then of course heavy exercise. So we need to figure out what's wrong first. Once we know what's wrong, then we address how to treat it. And traditionally, the starting point for a patient with PCOS would be letrozole, which we were just talking about before. Let me take one here. Okay, what medication do you recommend with TTC naturally when trying to conceive naturally? So yeah, we don't necessarily recommend medication unless there's something wrong. You can use Clomid or letrozole when trying naturally to try and boost your chances slightly. That is only if there is no reason that you're infertile, especially unexplained infertility, because the meds alone don't work for unexplained infertility. So otherwise, it's really vitamins. So coenzyme Q10, vitamin D, your omega-3 fish oils, folic acid, a prenatal vitamin. Make sure your weight is appropriate. Make sure your diet is low in sugar and cholesterol, high in antioxidants. Those are the basics. You don't really need too much. Sex every 2 days as soon as your period is done, and that's every 2 days for the whole month to maximize the sperm quality. So those are the essential elements of trying to get pregnant naturally on your own.
3% normal morphology. Should we go straight to
IVF?
I think they wrote IUI.
Yeah. So 3% normal morphology is below the World Health Organization's strict criteria for sperm morphology. It has to be at least 4%. That doesn't mean you have to go straight to IVF. You can go to IUI. I would probably, in that circumstance, recommend that you do a sperm DNA fragmentation test. And also, before you do anything, try and improve the sperm. So cold therapy, weight loss, avoidance of smoking, drinking, drug use, tons and tons of vitamins. We use either ProFertile or Fertile Pro. They're both great products and work really, really well for the men. So there are things you can do to improve your fertility and male fertility in particular that are very simple. I tell many of our guys to sit on frozen peas. Sorry, I know that's horribly uncomfortable. 20 minutes on, 20 minutes off. For God's sakes, don't feed them to anybody after you've sat on them. And wear underwear or else you'll stick. But the bottom line is cold testicles actually work better than hot testicles do. So stay out of a hot tub, stay out of the sauna. Don't take really hot baths or showers. And then that'll typically improve the sperm morphology. And, you know, it takes 3 months, so it can be a delay. So again, it depends on what's going on in your overall fertility history. Some people don't have 3 months, especially if there's diminished ovarian reserve. Other people do. So if you're young and healthy, definitely worth trying to improve the sperm. And then IUI is worthwhile. Even if you have high DNA fragmentation, we now use the Zymo micropore technique, which allows us to reduce the amount of sperm with high DNA damage by 90%. So it's a great technique. It works really well. We're only charging cost for that, which is $100 more than what we normally charge for our IUIs. And we're using that for a lot of our patients with very, very promising results. So there are options for you. You don't have to go straight to IVF. I got another one here. Hi, Dr. Victory. Hi. I suffer from scoliosis and often use a CBD cream for back pain. Right. Any concern for this? Okay. So if your CBD cream is actually functional, you must be absorbing enough for it to be getting into you. And we know that THC and CBD are not recommended in pregnancy. So I don't know if it actually works or not. If it's working for you, then it must be absorbed, I would think. And if it's being absorbed, it probably is not safe. So I'm sorry you're suffering from the scoliosis. That's obviously very uncomfortable. I would definitely recommend you see your neurosurgeon or spinal specialist before conceiving, because the pregnancy itself is going to carry a lot of extra weight, even if you're super fit through the pregnancy. And the problem with that is it is going to accentuate your scoliosis not only sideways, but also backwards and forwards, because your weight is out in front, and so it kind of pulls your belly forward. So you do need to be very careful. For all of my patients who have back problems, I always warn them in advance. Pregnancy can actually be quite uncomfortable. You need to prepare yourself. You want to strengthen your back as much as possible. You need to get a good masseuse, a good physiotherapist, possibly chiropractor. If you're seeing a spinal specialist, you need their agreement that it's even safe for you to conceive. So make sure you are dealing with all of those aspects before you jump in.
Updates on embryo transfers from TO to Windsor.
Right now the cryo shipping companies are not yet willing to go in, but again, I think they will be soon, and the fertility centers will likely be opening, again, quotation marks here, soon. So when they are open, we have literally hundreds, if not thousands, of embryos to move here. So we will be doing it as soon as we possibly can.
Last one that's early. Best way to retest for urea plasma if pregnant? Swabs or urine sample?
Swab for your urea plasma, because it hovers in your cervix. So the best way to do it is a swab. That's an easy one. So just get a swab done of your cervix, and that's safe. They don't need to go deep in, but just at the mouth of the cervix. It takes 5 seconds and it's harmless. No increased risk of miscarriage or complications or anything like that. I've got, is there a limit on how many months in a row you can be on letrozole? No. Letrozole is safe. You can use it pretty much endlessly with no risks whatsoever. In fact, it is unsafe for you to not regularly ovulate. So it is better for you to be on letrozole forever than to go through periods where you are not regularly ovulating. So letrozole is safe. It is unsafe to not be on letrozole. Okay, I've got some questions here then. Sorry, I'm looking sideways. We got multiple computers going here tonight. Okay, so let's start here. Sounds good in Seattle. Oh, safe and good in Seattle. Awesome. Hey, welcome from Seattle. That's amazing. We are glad to have you on board. Burned tubes. So someone's just commenting their tubes were burned. It is harder to put your tubes back together when they're burned. I will quickly do some graphics here for you so you guys can see it.
This is exciting.
Yeah, this is exciting. Okay, so there is your fallopian tube, and when we burn it, and your uterus is kind of over here. So when we burn the tube, we are burning from about here, backwards here, all the way out to about there. So about 3 centimeters. And the problem with that is, if I burn that much of the tube, I'm doing a lot of damage to everything in between here, and taking this end and putting it together with this tiny end doesn't always work that well. So if your tubes are burned, it is definitely harder to get them to go back together. It's still possible, but those are the ones where I usually tell you should consider IVF. Can this procedure fix scarring from ectopic pregnancies? So that's a question about, can the tubal reversal procedure go in and cut out the segment that's damaged by an ectopic? It could in theory, but then the procedure itself is definitely increasing your risk of an ectopic. So I would never advocate for someone to redo their tubes or have their tubes corrected because they've had a previous ectopic pregnancy, because I'm really just maintaining your risk of ectopic pregnancy. That wouldn't make any sense. So no, I would not say that it can be used for that purpose. Okay, just got a referral to you. Curious if you are doing a telephone appointments, or will I be contacted when you reopen? That's a great question. Thank you, Budding Beautiful. Yeah, so if you are coming to see us, or have been referred to us, I should say, sorry. Currently I am doing as many of my visits, whether they're new referrals or return visits, by phone or video as possible. We have a lot of, Instagram just paused, it says. Somebody says Instagram just paused out. On Instagram, can you tell us if you can still see us? The camera's good? Everything else is good?
Yeah, everything's That's Cameron.
Yeah, I still see some questions there. In any event, I'll continue. So if you're coming to see us on video, we do almost everything by video or telephone. And we have lots of great tech for that. So Zoom, Skype. I'm trying not to do too much FaceTime because it's my personal cell phone number. And then we also have other ones. No, I had to switch to Facebook. So people are saying,
reload it then.
oh no. Let me just see the other two questions.
Okay,
Yeah,
yeah.
go ahead. Yeah, you can reload.
Those are only two.
Yeah, I guess no, there's other ones, a whole bunch.
Get them.
You want to take a picture of that, and then we can.
Okay,
yeah, here you can take a picture of it. So sorry for the pause on Instagram, guys. Okay, so the other element of it is when we are up and running and we can bring you back in, we will bring you back in. So we're pretty confident about doing that at some point in time, but we're not quite there yet. And I think it's safer for everybody if we wait until later before we do that. So for now, we're holding off. Okay, any other questions on Facebook? Let's. Any suggestions to help with hot flashes while you're on Lupron? So the problem with treating hot flashes while you're on Lupron is that the only way to treat them is to take estrogen, which defeats the purpose of the Lupron. So, and we should be back on Instagram now, guys. So yeah, there isn't really great treatment for that. I apologize, but the whole purpose is to keep your estrogen level low, and the low estrogen actually is not great for hot flashes. So that doesn't work well. If you start taking aspirin for fertility and then stop, are you at an increased risk for clots? No. Or anything in the time after stopping it? No, not at all. So if you didn't need it, you were just taking it for fertility, there's no rebound effect where you're at a higher risk of DVT or PE, which are deep venous thrombosis or pulmonary embolism, when you restart. That should be fine. Sorry to everybody on Instagram. I don't know why I paused, guys, but we restarted. My husband and I have just started our IVF process and are in the testing phases. I'm currently ovulating and we are considering trying one more time on our own. What do you recommend? So Judy, all the stuff that we chatted about a moment ago. So vitamins, I'm not sure if you're back on Instagram or not, but vitamins, healthy living, sex every couple of days, like every 2 days, no smoking, no drinking, no drug use, appropriate diet. Yeah, the basics essentially. I think we lost part of one. Okay, I'll take the next question. Let me take one from Facebook. What is the success rate of IUI? So IUI can have variable success rates. On the low end, if you are just doing IUI, no medications, anything like that, it's around 5 to 8%. And on the high end, if you're doing injections and using the Zymo, you're probably getting up into the 30-35% range if you're young and healthy and the sperm is decent quality. So it can be very variable depending on you, the quality of the sperm, the quality of the procedure, our preparation techniques, and of course, whether or not you're using medication and then which medications you're using. Okay. What's going on over here? There's questions coming up. I can't scroll. Oh, there we go. If we're waiting for an FET, should we get started on the meds to prep for it? Not quite yet, but probably very soon. So I will let you know as soon as I know, and that should be later this week and into next week for an actual start date. Not that we will be starting later this week or next week, but we will know the start date within a week or two, we hope. Hi doc, do you deal with perianal fistulas in men? No, 100% I do not deal with perianal fistulas in men. Judy, I don't know if you heard the answer to your question. I'll just repeat it because I see your name there. But if you're going to try again, lots of vitamins Healthy diet, no smoking, no drinking, no drug use, sex every 2 days. That was the answer to your question you asked earlier. I didn't hear the answer to my question. Can you fix tubal scarring? Oh, okay. So the tubal scarring question, the Instagram request was not able to be heard. So if you've had tubal scarring from an ectopic, it would not make sense to put your tube back together because the putting back together of your tube causes an increase in the risk of ectopic. So that wouldn't make sense. So don't get your tubes put back together if you've previously had an ectopic pregnancy. Is it normal to ovulate after day 14 with a very regular 28-day cycle? It's not normal, but it can happen. Stress, dietary changes, temperature changes, all sorts of stuff. Okay. As embryos eventually come from Toronto, will you be doing transfers as they come, or is there a waiting list of people? No, we're going to do them as they get here, and we'll roll everyone into it, and we can accommodate any volume necessary. So we're going to try very, very hard to not have any waiting. Sorry if this was already answered. I am waiting to have my Let's Make a Plan appointment with you. We just finished all our testing. Are you doing these over the phone? Yeah. Right now, we still feel it's safest to do it on the phone or via video. And some of the video technology is pretty cool because with Zoom or Skype, you can screen share. So I can actually show you your lab, show you your pictures as though you were here in the office without having to worry about endangering anyone or endangering any of our staff. So we are still currently using the video or phone visits, but if it's really important to you to be here in person, I have N95 masks for myself. We give you a mask when you come in. We have air filtration systems from a company called Novaris, which killed coronavirus. We only let in one person at a time. We do not allow partners, so it would only be one of you. The other person would have to video conference in anyways. So yeah, you're more than welcome to come in, but we do it basically very, very, very rarely right now. So I think that was that one. And let me go back to the questions we had here. Can PCOS go away with weight loss? And can you tell or figure out what that weight would be? Oh, that's a great question. Okay, so PCOS can get better in terms of the symptoms it causes with weight loss, but it's built into you, so it's not going to go away per se. But we do know that women that lose weight, if they have the heavier version of PCOS, will definitely have a higher chance of ovulation and a higher chance of pregnancy. And we've discussed that on previous Fact or Fiction. So that's a very reasonable approach to things, and we would strongly advocate for that and recommend it. It makes your pregnancy safer. It makes it easier to get you pregnant. So yeah, definitely weight loss can ameliorate the PCOS. It doesn't necessarily correct it, but it does improve it for sure. And so we would strongly advocate for weight loss, absolutely. Okay, let me see. I think that was it from those questions. Yep. Okay, back to Facebook. Elena, someone had asked about the Sarnia clinic will reopen again. Will it open up at the same time? Yeah, I think it will. So I was actually just there 2 hours ago, 3 hours ago. The new clinic is essentially almost ready. We have a very few minor touch-ups to do. And then we are going to hopefully get that up and running as soon as we can. Our incredible manager there, Carrie, is going to have a discussion with me hopefully very soon, and we're going to talk about our plans to reopen there. So yes, Sarnia will reopen. I don't have a specific date for any of this because it's all dependent on what they tell us in regards to when we can all open, but it should be fairly soon. I am hoping sometime in May. And there is still setup to do in that office, so we got to get everything up and running first. But we're almost there, and I'm hoping to get everything done as quickly as we possibly can. It's a beautiful new space, and we've got everything set up correctly to optimize your care there. So we're real excited about that. Okay, back to Instagram. Hi, doctor. My cycle in March started at day 30, and I usually start at day 24. And for my April cycle, I started really early at day 21. Is that normal? If you're normally very regular and it's suddenly become irregular, that's not really normal. So there are some hormones we would want to check for you. For example, your thyroid, we got to make sure it's not stress related from all the COVID. You got to make sure it's not weight related also from all the COVID. There are some issues that need to be examined. Just let us know and we will check you out. Sorry if I missed it. Is the IG video out there for a bit? Does taking ASA for fertility put you at an increased risk? Oh, okay. So I answered that, but I will answer the IG part of it too. So all of our videos are up on Instagram for 24 hours and on Facebook, I think, as well.
Facebook forever.
Facebook forever? Oh, okay. And then they're on our YouTube channel, Victory Reproductive Care. So you can see all of the, we call it FFOF, Fertility Factor Fiction, online, and they're all there to review. However, the answer to that question is stopping aspirin does not have a rebound effect. You are not at a higher risk of clots or anything like that. So you don't have to worry about that. Okay, do you know how long the funding for IUI in Windsor lasts about before we have to start traveling to Sarnia? If it's like previous years, probably about 4 or 5 months. They woefully underfunded us and they refuse to listen when we keep telling them that. So usually by around August, we ran out. That'll be delayed now, of course, because we haven't been doing anything in April. So most likely, if I had to estimate, I would say September, October, but it is an estimate, so please don't hold me to that. We never know for sure. Hi, Dr. Victory. Hi. Are the companies that move embryos from one clinic to another up and running again? Not yet. But I am in discussions with them, and I think we'll probably be able to convince them to do a one-time shipment of a large number of embryos, and that's kind of the plan in general. So I think we'll be able to get some traction on that. If I froze, not blankets. Not blankets. I don't know what. Masks. Masks, not blankets. I'm not sure what you mean, Di, but anyways. If I froze embryos with you and they are at Nahal as part of the Fertility Preservation OHIP covered program, does this mean I would have to stay with Nahal if I were to need IVF in the future in order to have that part OHIP covered as well? Okay, so let me be super clear about that. For all of the patients that have embryos at Nahal, I want you to be super comfortable making whatever choice is best for you. So you do not need to decide to stay with us if you are comfortable staying with Nahal. Currently, the medical director there is Dr. Payman Mazidi, and you would be doing everything with Dr. Payman Mazidi and the Nahal program, and they would be making all the decisions. They have to arrange for your monitoring. They have to make the decisions on your monitoring, and he would be doing your transfer. So in order to stay in the funded program where the government is paying for your cycle, you must stay with them and with their program. If you do not mind coming out of the program, so you don't have to pay, unfortunately, for your embryo transfers, which is honestly what the vast majority of our patients are doing, then you can take your embryos at no risk or anything to you. And there is no permission that is required. You do not need to check with the ministry. You do not need to pay for your previous cycle, nothing like that. There's a transport fee and a small fee to Nahal to place the embryos into the cryo tank, and then essentially they're ready to move. So that's the only part, and we are going to waive our monitoring fee to offset the costs of the move from the hall to here. So we're trying to give you a bit of a break as best as we can. So that is the answer there. I live in, I missed one. When people talk about funding, what does this mean? Like the previous question about the IUI funding. IUI in Ontario, if you're an Ontario resident, is funded partially by the government. So they pay for monitoring and the testing and the process of the IUI. You just pay for the sperm wash. So the funding is the allocation from the government to the process of the IUI. I live in Chatham. You always mention to talk to MP about funding. What would I bring up? Would love to get funding here or more in Windsor. I'm doing paid cycle in Mississauga. TTC 6 years. Wish I knew about you before. Hi, Randy. You can come here now. You don't have to go to Mississauga. And we are happy to take care of you. That's a long drive to Mississauga from Chatham. So you can go to our Sarnia clinic when it's open, or you can come to Windsor. And for the MPP or MP, you just need to talk to them and say, we need funding, more funding for Windsor, so I don't have to drive all the way to Mississauga. This is unfair. We're not getting enough resources. Why is Toronto getting the lion's share and we're not getting enough? Yeah, absolutely. Okay, I'm missing some Instagram questions here. Sorry, guys. Here we go. Thank you for doing what you do. Also super thankful for the FOF you do. Made meeting you more comfortable and love being educated on everything. Oh, so thank you. Thank you. And you were lovely to take care of. Do you ever recommend VBAC for women? Oh, a VBAC. VBAC is a vaginal birth after cesarean. We now call it a TOLAC, which is a trial of labor after cesarean. For women over 35, yeah, absolutely. Your age is irrelevant. If you've only had one previous section, they did a 2-layer closure, which is this and then that, and they sewed both times. So first sewing here and then sewing up there together. Yeah, you can definitely have a VBAC if you want one. There are risks. The risk is that the uterus can tear open. It happens somewhere between 1 in 200 to 1 in 600. I've only actually seen it once in my career, so it's pretty rare. But it can happen, and if that happens, that's a problem for you and for your baby. So there are some risks. You need to talk to your OB about it. Why doesn't letrozole or Clomid help with unexplained infertility? Because it doesn't. So unexplained infertility has those patients have a 3.8 to 4.1% chance of successful pregnancy every month. And when you put them on letrozole or Clomid alone without IUI, their chance is between 3 to 4%. So it doesn't help. Why it doesn't help? Simply making more eggs when we don't know why you're infertile just doesn't help. That's not the problem. So it's not doing enough to correct the problem. Okay. If we paid for keeping our embryos frozen at Nahal, will we have to pay again to keep them in Windsor? Yes and no. So your freezing at Nahal should be prorated for the period of time. So if you kept them there for 3 months, they owe you, the other 9 months back because you're not keeping them there. So you have to get your money back for the other 9 months. And we would just charge you the same way for the period of time that you keep them frozen here. So you won't be paying anything differently than what you'd be paying had you kept them at Nahal. Thank you for doing these videos. So informative, super interesting, and helpful. My pleasure. Love doing them. I'm happy to continue. Okay, I think we're winding down to the last few questions. I have an appointment tomorrow. Oh, for the monitoring? Yes. So if your periods have gotten a little crazy, when you come in tomorrow, ask the girls to run day 3 labs. They will know what I'm talking about, and just say, I mentioned it to you last night on the show specifically. They'll take care of what you need. Can G6PD affect fertility? Wow, that's a great question. So G6PD is glucose 6-phosphate dehydrogenase deficiency. Your red blood cells split open in response to certain foods and mostly medications. Fava beans are the big one for food. It's common in Middle Easterners. So I'm not aware of anything that says that G6PD screws up your fertility. Someone near and dear to me carries G6PD and had 4 kids, so I don't think it does, but I'd have to look that one up. See, I always learn something from doing these. Yeah. Okay, a couple of quick Facebook questions, and then we got to call it quits, team. Hi, Dr. Victory. Is having a fibroadenoma during pregnancy something to worry about? A fibroadenoma, meaning a breast fibroadenoma? Absolutely not. You never need to worry about those inside or outside of pregnancy. They're totally safe. So that's fine. Sheena, unsuccessful IUI in April, unfortunately. During the procedure and a few days after, I was having some light bleeding, brown spotting. This did not happen during my successful IUI back in 2015. Since I ovulated this recent cycle a few days ago, I've been spotting again. Well, if you haven't had a saline infusion sonohysterogram done, you probably should. And somebody should be monitoring your lining during the cycle. So make sure that we monitor your lining during the cycle to see if there's a polyp or a fibroid or it's not thickening enough. Hi, Katie. Any idea of when we may be able to start up again? I've talked about that a few times so far, but for you, I'd go to the ends of the earth. So we're hoping in the next couple of weeks that we will be able to do that, but we are waiting for the guideline to be established. The final format I just received in my email today. They're planning a discussion call, and then all of the physicians in Ontario need to get on a teleconference to decide when exactly we're going to reopen. So should be soon. Praying we can figure our situation out. Yes, me too. Okay, last one. You said your mom made beautiful blankets. I think she was correcting you and saying mask. Oh, yes. Sorry, Mom. She actually makes us beautiful blankets as well. But she made us beautiful masks. So she made us a whole bunch of masks, even with the little metal in it. And little rubber bands or rubber material to hold the around the ears. So thank you, Mom, for making those incredible masks, not blankets. Okay, one last one. Oh, asking because I just had a miscarriage, that's why. No. Does a polyp cause miscarriage? Yes, polyps can cause miscarriage. Almost doubles your rate of miscarriage, so that needs to be evaluated. Okay, I see someone near and dear to me just joined at the end of my show. So for that near and dear person, honey, I love you. I'm on my way home now. Thanks everybody for another great show. Look forward to your questions as always. And if there is anything that we can do, you can ask us. You can always email info@drvictory.com. Many of you have found other creative ways to reach out to me and get a hold of me. And we do respond to those. You can get to us through our awesome website set up by Ibrahim Strategies Group, and Tarek has done a lot of the legwork there. And as well, you can get invited to our email portal. And the email portal lets us communicate with you and log it in all of our electronic medical record system, which is hugely helpful for us. So if you want to do that, by all means, we can invite you to the portal, and we will be sort of mass emailing everybody so that they can get invited to our portal. As always, thank you. Like, comment, share. We love the likes. Those are really helpful. And if you guys can continue supporting us, that would be amazing. Okay. And I will look into some stuff. Our office manager is texting me something about embryo funding transfers, so we may have some homework to do. More exciting stuff for next week. We will be back next week. I'm not sure if it's Monday. Is it Monday? Next week is Monday again. We look forward to having you guys. If you guys want us to do another show in the, at the end of the week, like a Monday, Friday thing, once in a while, we can probably accommodate that too. In order to do that, I would need you to throw a topic at me, or maybe we can do a little abbreviated half-hour show and just answer more questions for you. So if that's something you want, again, throw up lots of likes, send us the comments, tell us that that's what you want us to do, and we will definitely look after that and make sure that that happens. Thanks to you all. As always, be safe, self-isolate, make sure that you are taking every precaution that you can. And I do want to thank my wife and my kids who put up with my long, crazy hours of being not home. Believe it or not, this COVID thing has made me work harder than ever. I'm here 7 days a week. I love you guys. You are making a huge sacrifice for all of us and for all my patients. So thank you. You're all amazing, and I hope you guys are all having a great night. I'm seeing lots of thumbs up on Instagram for the little half-hour show. I will see if we can put something together. So you guys have a great evening. Thanks again for joining us on Fertility Fact or Fiction. We're going to sign off now and take care.